Good morning, everyone. Delighted that there's so many people joining us this morning I was about to say what day is it? It's Tuesday on a on a Tuesday morning in March. This is our second Simon Talks of the year. We had our first one with Conor O'Toole from the ESRI. He usually kicks off our year every year, Naomi. People love to talk economics at the start of the year, you know. Um, so I'm going to start being quiet now, and I'm delighted this morning to be joined by Naomi Nicholson. Part of the Simon communities across Ireland is the incredible work that's been done in different communities and regions, and we're really, really delighted that we get to spotlight Usher's Island, the Dublin Simon service this morning. So Naomi is the Director of Clinical Governance and Therapeutic Services at Dublin Simon, and is going to speak to us this morning about the excellent and innovative Usher's Island service. Naomi has been a mental health nurse for a number of decades. We're just talking about that, and has a keen interest in service innovation. And I think that's going to come through when people hear a bit more about the Usher's Island facility. So I'm going to be quiet there. Naomi, do you want to share your screen? And I'll jump off. I'm going to mute myself and turn off my video. And then when Naomi is ready, you'll let me know when to come back on, and we can go through the Q&A function there.
Okay, lovely. Thank you. Well, welcome everybody, and thank you for taking the time out to listen to this webinar today. I'm going to talk you through a bit of a whistle-stop tour through the Usher's Island Health and Addiction Care Facility today, and some of the pathways and how they might interlink and how they connect to the rest of the community. I will start. Usher's Island Health and Addiction Care Facility was funded through the Department of Housing, through capital investment, through the CAS programme, with the HSC delivering core service funding within the building. So it opened in phase stages in October 2024, opening with original 51 beds that moved. Originally, it was in Usher's Island a few years ago, and those services moved out, decanted. So the new Usher's Island could be built, and those 51 beds moved back into Usher's Island in October 2024, and we've gradually had a phased opening, and we're currently up to 75 beds out of the 100 beds that are currently operational, with a view to get up to 100 beds in due course. And what's really unique and fantastic about Usher's Island is that it reflects a fully integrated approach to complex health, addiction, and homelessness needs. So, working with obviously an NGO, Department of Health, and Department of Housing. So, shows really, really fantastic integrated working. So the building, just to talk you briefly through the building, like I said, it's 100 beds. It was purpose built with lots and lots of thought around trauma. So lots of thought was put into that. One of our property people, Wario Moore, was very instrumental in making sure that the building was really, really well thought out. They're all ensuite single rooms, which is quite unusual actually in the homeless sector. But obviously, again, with trauma in mind, it's been quite a game changer in terms of people feeling safe and secure within our services. We have counselling and one-to-one rooms. We have group rooms, obviously for groups. We have a conferencing facility, so we host lots of training, and people come and use the room. External people and people within Dublin Simon come and use the room, and we use it for our own training purposes as well. We have a fully equipped kitchen for freshly cooked food on site, which is fabulous. One of the things that we know works really, really well for healing, for physical and mental health, is good nutrition. And we have already, well, last year we received the Bronze Award from the Irish Health Foundation, and obviously we're now working up through to get accredited even further for that. We've got a fully equipped dining room, which is a cafe style. It's beautiful. It doesn't have the feeling of, or it has a feeling of a restaurant, which is lovely. And we also have a fully equipped gym, and we're in the process of recruiting a gym instructor, which again is fantastic when you're thinking about holistic care. We're not just thinking about the medical model, we're thinking about physical health as well. So the building is amazing. It's a wonderful, wonderful place to work as well. And I know that people that work there are really happy. Our retention of staff, I think, obviously it's a nice atmosphere, but I think the building has got an awful lot to do with our staff retention. Our staff retention, last time I looked, was at about 6%. Not retention, attrition, because retention at 6% would be really bad. Our attrition was around about 6%, which is absolutely phenomenal. So why is the service needed? I'm sure the people that are joining the call probably know why the service is needed, but I think it's good to ground us in and remind us why it's needed. We all know that homelessness is very complex. It's not just about housing, although obviously a huge part of it is about housing. And we know that things are getting worse in terms of the housing crisis. We know that addictions often go hand in hand, including polysubstance use. We've seen an increase in polysubstance use in recent years. We know that health complications are common. We have an ageing population, and one of our strategic areas of focus is on complex health needs and an ageing population for Dublin Simon Community. So unfortunately, we had 12,067 people in emergency accommodation in Dublin as of December 2025, which was a 13% increase on December 2024. And I think roughly about, let me have a look at the stats, about 8,184 of those in December were adults. And children and families, 3,883 were children and families. So a real crisis, I would say, in terms of the increasing numbers. So if ever a service was needed, it's needed now. So at 100 beds, the Dublin Simon Community Health and Addiction Care Facility at capacity can support between 1,264 to 1,450 adults annually, which is a significant amount of adults when you think about 8,184 adults, single adults were homeless in 2025. One of the other amazing things is that this service really, really lends itself to Sláinte care, so fair, timely, community-based health and addiction care for people experiencing homelessness. So Sláinte care is obviously, it's community-based, it's meeting people where they're at, it's integration, it's all of the things that I think that this service does provide. So the service was core funded by the HSE for services covering Greater Dublin area and Kildare. And just to briefly run through what our staffing model is, I know I put this in here because a lot of people ask what's our model. So just to say that it's nurse-led in clinical services, and then we have non-clinical people managing and running our non-clinical services, which in Usher's Island is our recovery service, our recovery one and aftercare. We've got a mix of general nurses and mental health nurses, and we have clinical managers and non-clinical managers. We've got supervisors, project workers, and support workers. We have a bed flow team, and we've also recently appointed some care navigators, which is fairly new to Ireland, care navigation, which supports integrated care. So it's that bridge between the community and the Usher's Island care facility. So really, really making sure that people are integrated and connected back into their community supports at the point of entry into our service. There's a real focus on that. We have GP supports from Safety Net, and we have a GP supports with Dr. Dawes Clinic for the detox service currently. We have tissue viability nurse services that's currently sit in primary care, but we're in the midst of recruitment into Usher's Island for a second tissue viability nurse. But we do have a fabulous nurse prescriber who is an expert in tissue viability that does in-reach into our services currently. Shortly, we'll have our own. And we have working within our services a continuous improvement team as well. We've got a real mindset of continuous improvement within our services, and we are in the midst of implementing the model for improvement across our services using PDSA, Plan, Do, Study, Act. As our model for continuous improvement. And that's very much embedded into our governance processes, which I believe are very strong within our services. And clearly, obviously, need to be. And then we have a full operations team that support our services, which includes reception. So we have reception. We have reception during the day and evening currently. And again, we're just in the midst of onboarding some night porters, which will help with the security and operations of our service, as well as a fantastic operations team. So good support, actually, for the service to run. In terms of integration, we work very, very closely with acute hospitals. We work with inclusion health teams, methadone prescribers, community GPs, the PACT team, community addiction services, Housing First, and other NGOs. And the list isn't exhaustive. We have something like 45 to 50 unique referrers every single quarter. So a number of referrers refer into our service. And that just gives you a bit of an overview. So to talk you through our individual clinical services and recovery services, we have an 11-bedded alcohol and detox service, which provides 3-week alcohol and 5-week benzodiazepine program. Methadone dose must be stable for more than 7 days before admission. That's part of our criteria, but people can come in on methadone, like they can with many medical detox services. What's different about our low threshold service is that people can then move on to recovery and don't have to be off a stable methadone or prescribed medications. It's a strictly drug and alcohol-free environment within our detox service. And just thought it'd be nice to give you a bit of a case example. So we've got there a chap called, these are all made up examples, but quite fairly representative, I would say, of what we offer. So we've got there, Liam has been binge drinking, using cocaine at weekends and drinking heavily. Most nights, alcohol use has escalated to the point where he's experienced morning shakes and anxiety. After pre-assessment, his GP confirmed he's medically suitable for alcohol detox and he must understand he has to abstain from cocaine use on admission and obviously alcohol and any illicit substances. Liam's close monitoring in the first week, and he's referred to detox to safely medically and psychologically support withdrawal and begin a supported recovery plan. When people come into medical detox, we always really want them to go onto recovery if that's where they're at. That's the ideal from our perspective. That's just a case example. So moving on, we've got 22 step up and step down beds. So this is a low threshold service for short stay medical admissions up to 3 weeks. Step up referrals from the community from community clinicians, and step down referrals are often from hospital teams. Harm reduction model. So it's abstinence. So abstinence isn't required. That lends itself to the low threshold element there. So it supports clients with complex or chaotic substance use, but it's not a stabilisation or drug stabilisation unit. And just to give you some examples from a step up perspective, John has been struggling with a flare-up of his COPD whilst living in emergency accommodation. GP feels that he needs a short period of nurse-led support to stabilise his breathing, review his medications and monitor him safely. He's referred from the community, from the community for community step up for 3 weeks so he can get medical care before things worsen. And this is really, really helpful in terms of hospital admission prevention. We know that there's lots of pressure on acute services and on A&E and acute medical services. So actually having a prevention model is really helpful and can save the taxpayer significant amounts of money when you compare the cost of an acute bed to the cost of the beds that we provide. So from a step down perspective, case example is Maria has been discharged from hospital after treatment for a severe leg infection. She's medically improving, but still needs wound care and dressing changes and monitoring that she can't manage alone. The hospital team refer her to step down so she can continue recovery in a safe and supportive environment. Again, many people can be stuck in hospital where their needs aren't sufficiently met because it's not the environment to meet their needs. They need a community-based setting. They can't go home because they might be living, they might be street homeless, or they might be living in quite chaotic accommodation. And they may not always be able to get their needs met by visiting supports. So this is a really, really good way of people getting that ongoing support. And again, the cost of that maybe earlier discharge is quite significant to the taxpayer. So that's a step up, step down, 2 examples. There are many, many more. We work with people with mental health needs as well. You know, from a step up perspective, we've taken people and started them on clozapine medication for treatment-resistant schizophrenia, and we've had some real successes working with the mental health inclusion team there. So we take in people with physical and mental health needs. We don't take people that so we've got quite strict criteria in the sense of we will take people whose needs we can meet and we won't exceed what we can't do. If somebody needs an acute care setting, so if they need acute mental health care, or if they need acute medical care, we have a really, really good, robust assessment and referral pathway to make sure that we don't overstep and work not within our scope of practice. And that's really important from a safety perspective. We have very, very few incidents, and that's reflective in our incident statistics, which shows that we're very safe. And then we have eight blood-borne virus beds. So this is up to 6 weeks, suitable for people with blood-borne virus or active hepatitis C. So active hepatitis C or HIV, or people that are HIV positive, with complex presentations, both mental and physical health. Again, it's not an abstinence-based model, so there can be substance use as long as withdrawal risks can be managed safely and the client is willing to engage in harm reduction and reduce the use approaches. We only have one service where we don't allow people to have access to the outside world unsupervised, and that's our stabilisation service. Even in detox, after the first week, if people are fit and safe, they can have a couple of hours out in the community with some testing and screening when people come back if they're in detox. And in our blood-borne virus service and our other services, we very much take an harm reduction and reduce the use approach, and our groups are surrounded with that model. And again, a case example for the blood-borne virus unit would be that Sarah's living in supported accommodation. She's recently been diagnosed with Hep C. She's been feeling quite overwhelmed managing her physical health, mental health, and occasional substance use. And her GP believes she'd benefit from a short stay where her treatment can be coordinated and she can work on reducing her safety. Sarah agrees and is referred to the BBV unit for up to 6 weeks of structured low threshold support. The big difference about the BBV unit is that people don't have to be registered homeless in the fact that they can have their own accommodation. So this is very much a public health service as well. We know if people are living chaotic lifestyles and they're not taking their antiretroviral medications, or they're not getting treatment for Hep C, that's not just a health risk to them, it can potentially be a health risk to the public as well. So we want to be able to support anybody that might have a transmissible disease. And then we have a 22-bed phase one addiction recovery beds. Now, this is part of a whole addiction recovery pathway that sits outside Usher's Island as well. So we have the 24-hour supported 22 phase one addiction recovery beds. And I'll talk a little bit later about the whole of the pathway that's phased support for up to 2 years for recovery. So this is for people who've completed a medical detox. It's an abstinence-based program, but people can be on stable methadone or they could be on prescribed medication as well. That is allowed, which is different to some other services in Ireland. We use a CRA model, so it's a community reinforcement approach model. And it's 3 to 6 months group program, and it supports engagement in the community. And discharge requires stable accommodation. We always try and aim to discharge people to stable accommodation as much as possible, and we will often encourage people to go through the stages of recovery, stages 2 and 3, that are community-based services within our own pathway. As part of this pathway, we've got our 2 ring-fence beds for pre and postpartum women. A big area of focus for us is women within our strategic focuses, and I'll talk to you a little bit more about that as well, and I'll give you a case example. So, after completing her medical detox, Aoife wants to build real stability. She's ready for abstinence-based program, but can stay on her stable methadone script. Recovery phase 1 gives her a structured 3 to month routine with daily groups and community reinforcement approach support. We try very much, although we have groups inside our service, we try very much to encourage from day one people going out and connecting to the community and gaining support and building recovery capital in the community. We know that's what supports, and the evidence shows supports and sustained ongoing recovery. So this will help her rebuild confidence and link into community programs. And then from a pre and postpartum pathway, as one example, after completing her treatment in Kundara, which is a treatment service as well within the HSE, Sarah gave birth to her daughter in the Coombe Hospital. Due to ongoing safety concerns, sadly, her baby was placed into temporary foster care. Although Sarah's heartbroken, she's determined to return to recovery service and to stay stable, which often the pathway can be if a child is taken into temporary foster care. The mother, after doing all of that hard work in Kundara, may end up back in unstable short-term accommodation and end up in very difficult circumstances and may end up going back to use. So we worked very, very closely with the HSE to have these 2 ring-fence beds so that in these cases, Sarah could come back into our recovery service, continue to rebuild stable routines, strengthen the recovery, and then by working together with maternity services, social work and Ashley House, we can support Sarah to work towards a reunification plan so she can safely parent her baby. And this really lends its hand to what we're really trying to do in terms of encouraging women into our recovery pathway and into our recovery services. Very few women make it to recovery, so we're really trying to change that narrative because if we want to change and influence generational trauma, it's working with women. Our focus really needs to be. And we've been quite successful, actually. We've had a number of women since we started this work last year work through and have reunification with their children, which is absolutely amazing. And I know it always makes the team really, really happy when that happens. And then last but not least, in terms of our clinical services within Usher's Island, we have 12 addiction stabilisation beds. This is our newest service, probably one of our most challenging because it's something we've not done before, but things are starting to improve, which is great. So we have 12 addiction stabilisation beds. They're closed beds, so we don't allow people to go out into the community unsupervised. We have quite a strict structured therapeutic programme with a harm reduction based and abstinence based service. It supports people in chaotic polysubstance use. Abstinence is expected during the programme, and all outings are fully accompanied for the entire stay. Those needing alcohol and benzodiazepine detox are redirected to detox services. So just to give you an example, Mark has been sleeping rough or using cocaine and alcohol and tablets to cope. His use has become chaotic. He's struggling to keep himself safe, and his GP feels that he needs a structured, closed environment where he can stop using, be accompanied on all outings, and gets therapeutic support. Mark is motivated to change, and he's already established on OST, so he's referred to the stabilisation unit for a 3 to 6 week harm reduction programme to stabilise and prepare for longer term recovery. We've seen some good examples through this service of people moving through pathways. So there are some people that have moved on from stabilisation straight into recovery services, which has been fantastic. Similarly, because of the actual environment that we work in now, we've seen people go from BBV who have become abstinent in their substance use and have made it through to recovery services, or have decided they want to go on and go into detox or into stabilisation, because they can see people improving and getting better. So there's been lots of internal movement through the pathway, which has been fantastic to see, because people are all in one building. So Usher's Island isn't an island, despite its name, and we have a number of wraparound services that support Usher's Island. So we have client development, which works on helping and supporting people to build recovery capital, reconnecting people back into the community, looking at vocational courses, looking at group work, supports like that. It might be literacy, it might be computer work. The client voice is very, very integral to the client development team, and they work fantastically across Dublin Simon and do an awful lot of work on our group programmes within Usher's Island as well. We have a primary care service and primary care team. Our tissue viability nurse and nurse prescriber sits within that team as well at the moment, and they are very much a connection to our STAs, our LTAs and our outreach service, and have an awful lot of referrals come from primary care into our Dublin Simon Community healthcare addiction facility. We've got a counselling and suicide prevention service, so we have dedicated counselling hours within Usher's Island, and we have a flexible approach to counselling. So we do one-to-one sessions, but we'll also do drop-in sessions as well, to be more flexible, so people don't feel that they have to do formal counselling. They might just dip their toe in because we're meeting people where they're at for certain services. It might then mean that they want to go on and engage in proper full-on counselling. But it's a nice, gentle way and a low threshold way of meeting people where they're at. We also have some specialist counsellors, some counsellors trained in specialist EMDR, trauma therapy, which is a specialist therapy with very good outcomes for trauma, simple trauma and now complex trauma. The evidence is really good for that. And as part of our service, we have the NOS funded part of that service, which is suicide prevention as well. So very much focusing on what it says on the tin, is suicide prevention. So we have an out of hours service as well. We have the REACH programme, which supports clients pre and post discharge. So it's very much engaging clients with a community reinforcement approach. Again, connections to the community, connections to recovery and building recovery capital. And they work with people right through our Usher's Island services, but also right through after discharge and in services for aftercare as well. And it's just had a rebrand from aftercare to Reach. So if people are wondering what Reach is, it was formerly known like the artist Prince as aftercare. And then we have our recovery pathway, which is recovery 2 and 3, which is a community-based recovery pathway that works with people who've completed a recovery detox program, and they go into the community for to Klonsky first off, if they wish to, and they will work with uh, it's not 24 hours, so it's Monday to Sunday supports. Um, and there's no overnight cover, but there are overnight emergency ports if they need it. And then from that, if they spent a period of time there, they may well go on to our Dean Swift service, which is in reach support from a project worker. Again, it's not 24-hour support. And then they're more ready and more able, and they can stay on that pathway up to 2 years actually. And then they're more ready and able to go on to full independent living. So it's a really, really good full pathway if people wish to go onto that pathway. So how we work. So we work in a low threshold way. We meet people where they're at. Again, I've described the low threshold services there. So, our recovery services, methadone, prescribed medication isn't a barrier to going on to recovery. Coming into our BBV unit, if you're not abstinent, isn't a barrier to getting in. Coming into our step up, step down services, if you're still using substances, it's not a barrier to coming into our services. And that's why we allow people to go out and on leave for short periods of time. We are trauma informed within our services. And we know we want to get better at this, as I'm sure lots of services do. So we have currently a pilot project going on in Dublin Simon Community. We're piloting it in the interest of continuous improvement. So we're going to make our mistakes or do our learnings in very small ways. So we've got 4 pilot sites across Dublin Simon to embed trauma-informed practice, which is 2 in Usher's Island, 1 in the recovery service and 1 in our clinical services, which is step up, step down, and then 1 in an LTA and 1 in an STA. And our focus is there. Is to look at our environment from a trauma-informed lens, to look at our practice, so how we work with people, to look at our policies and procedures, and to have some really, really robust training around trauma, and to work really closely with the teams on that. Like I said, do all of our learning and get all of our iron out all of our crinkles in those services, so we can then do a spread across all of our services and roll out a really robust way of embedding trauma-informed practice into all of our services, as opposed to just training people. So we live and breathe trauma-informed work. So we're really proud of that programme that we're running at the minute, and we have a fantastic project lead and admin supporting that. And then the community reinforcement approach is another way of working. And I've mentioned community reinforcement approach a few times here. So this we also have a project lead that's about to start on the embedding of community reinforcement approach across our services. So it's making sobriety more rewarding than substances. It's reinforcement of positive behaviours. It's identifying and changing triggers, so using functional analysis. It's building practical life skills to build recovery capital. It's about strengthening pro-social recovery supports and relationships and community engagement. So important. And like I said, we start the community engagement piece right from the very beginning, particularly in detox. And that's why we encourage people to spend short periods of time out, even in detox. And then certainly that ramps up when people get into recovery services. Yeah, so that's where we're at. I'm nearly finished, so you don't have to listen to me too much longer for talking. I'm just going to show you a short digital story that one of our clients worked collaboratively with one of our members of staff and our communications team to develop. And this is a short digital story about her time prior to Usher's Island and then coming into Usher's Island. Yeah, it's just a very short clip, but it's fantastic. A lot of work was put into it from her. To play the clip.
A year ago, I was a ghost. I walked through the streets of Dublin feeling as though I didn't exist. And the truth was, I didn't want to exist anymore. If you'd seen me then, huddled in a doorway or shivering in a tent, you wouldn't have known that I came from a decent background. My descent didn't happen overnight. After my college days, an abusive relationship accelerated my drinking. The more I drank, the more isolated I became. Years passed in a blur of hostels and rough sleeping. I lived through the beast from the east, praying not to sleep in sub-zero temperatures. Last December, my life came to a halt. I was admitted to a hospital with pneumonia, severe infection, and alcohol withdrawal. I spent months there and I had no visitors. That was when a miracle happened. The Dublin Simon Community opened their detox and recovery facility. It saved my life. For the first time in years, I had dignity, a room of my own, a door I could lock. Because of their support, I'm now back in college. Today, I'm no longer a ghost. I have a purpose, I have a future, and I have hope.
Hi. Are you ready for your assessment?
So hopefully you got a sense of just one of our women that have come through our service last year. It has done phenomenally well. One of the big things that a lot of our women, actually anybody that comes into our service, is that they feel a sense of safety, which is so important for recovery. You know, the physical building has made a huge difference. Obviously, the way the staff are and the way they interact is important as well. But the sense of safety people feel having a room with a door that they can lock and an ability to have a shower in peace, it really lends itself to a sense of safety within our services. And lastly, I'm just going to talk to you about one of our big strategic focuses, and I alluded to earlier, which is around women. So we know that women have difficulty accessing services. There's often a reluctance to access services for a variety of reasons, or an inability to access services. There might be some coercive control going on there. There sometimes is. There might be some hidden homelessness, so they might not be registered homeless, but they're sofa surfing, for example. And they often come to our services with very complex needs because they haven't engaged earlier or they've experienced significant abuse that's continued through to adulthood as well. I'm not saying for all, but it's a common theme that we have with women. So we know we need to increase the number of women that access our services, and we have to do that in a very proactive way. So some of the ways that we're doing that in Usher's Island, it goes wider than this in the rest of the organisation, but in Usher's Island, we're particularly trying to proactively triage vulnerable women. So if there is somebody that's street homeless and particularly vulnerable, we'll proactively triage and prioritise that person to come into our service. Over and above somebody that might be in a relatively stable or supported accommodation. We have a women's health nurse and healthcare assistant in the with an assertive outreach approach. So they sit within primary care. This is a new role that we're piloting at the moment, and they're working proactively within our STAs, mainly our STAs, our LTAs a little bit, and with the outreach team to proactively work with women to engage them in community appointments and hopefully if they want to engage them in our services as well. And then we have, like I alluded to or talked through earlier, 2 ring-fence beds for pre and postpartum women in recovery. And then we have a women's health clinic starting with cervical smear testing about to commence shortly as a bit of a pilot within Usher's Island. A lot of women don't access healthcare in the way that we do. So we're starting very, very small with cervical smear testing. And we hope once that goes well, we'll hope to broaden that to general women's health clinics within our service. They're just a couple of things that we're doing within Usher's Island. Against the wider project that's going on within Dublin Simon. So thank you. And are there any questions? You can refer via the portal online, and there's queries to referrals, and there's my email address there if people want it. So there you go. I'll stop sharing and I'll stop talking because I've talked a lot.
Thank you so, so much, Naomi. That was, it's a pity that you can't see people because I'm sure others were nodding along or kind of, smiling as you were saying different things. It's such a fabulous, fabulous facility. And I think one of the things that's really struck me is you can tell how much you care about people accessing the services. So even how you speak about that, so I can just imagine, how that permeates across the team. And I was lucky enough, Catherine Kenny, CEO of Dublin Simon, very kindly brought me on a tour of the facility at one point last year. And it's beautiful. There's so much light, like it really, and I think that's, you brought that in as well around the environment and that kind of the therapeutic environment. So we have a question in from someone. There's actually 2 questions in it. And one of them I had been wondering myself, and it was, is there a long waiting list for the services?
It depends. So for step up, step down, you're looking at 5 to 7 days. So not
Okay.
long at all. Detox is a little bit longer. So the waiting list is so it's as long as a piece of string with a waiting list in a way, because some people it's not a chronological waiting list because detox obviously the service lasts a bit longer. So people are in it a bit longer. So inevitably the waiting list is going to be slightly longer. Whereas step up, step down, the turnaround is every 3 weeks. So a waiting list of 5 to 7 days is about right. For detox, it can be about 3 months, which is longer than we want it. But some people, if they've got a major priority, can get in. If they're really, really vulnerable and at risk, we will it's on medical need really. So they may jump the queue and get in sooner. If the risks are high for that person, they'll kind of queue jump because it's not chronological in that way. So
Yeah.
that's an example for that. For recovery services, it can be a couple of weeks. And for BBVU, a couple of weeks. So it's quite short, apart from detox, which is slightly longer.
Yeah.
In the scheme of things with detox, some services out there can be benchmarked against, 6 month wait, even a year wait. So not too bad.
Yeah, and I suppose the fact that there's a wait at all just shows the
Yeah.
need for the services. And as part of the second part of that person's question, was around the impact of the housing crisis, on individuals and how does the housing crisis challenge their success on the program? So, like the challenge to secure emergency accommodation or allocations for them could lead to delays, which could impact relapse. So, is that something that you're seeing in the service as well? That impact of the housing crisis, I suppose.
Yeah, it does. I guess we see it. We see it a lot or we see it more probably in the recovery services. So if people do all of that really, really good work, I think particularly at the end of people's journey with us, although it never ends because we've got REACH program, and we can continue that support. But people can get very, very anxious. We did some studies a few years ago that look at people in recovery phase 3, and the anxiety and stress of not knowing where their accommodation's going to be from that service can on occasions trigger relapse, which is something that we're trying to proactively work with with the housing providers. So yeah, it can happen there. We try and support people to go into the most stable accommodation. Like, say, if somebody's in detox and they don't want to go on our recovery journey, we wouldn't want to discharge them to the street. Like, we
Mm.
always want to discharge them to the most stable accommodation there is out there. But the reality is the numbers are increasing, and there aren't enough suitable houses.
Yeah, and I'd probably go as far to say as well that the housing crisis and the stress around, accessing the private rental sector or HAP or things like that will be exacerbating mental health difficulties or addiction, because it's such a stressful point, to even navigate
Yeah.
getting on the social housing list and getting the supports needed.
Really, really is. It's very
Yeah.
sad as well, because people, an awful lot of people, especially if they've done an awful lot of work, to then people have to go back into circumstances where they've got very, very well, their chance of surviving in that environment and staying abstinent is really compromised hugely.
Yeah, yeah, there's so many impacts of it.
Yeah.
So Alicia Fahy, the lovely Alicia from our Midwest Simon community, has a question there saying, can you take referrals into Usher's Island services from outside of the Dublin region? So I suppose, do you have a catch, or is it just Dublin Kildare? Is that the catchment area?
It is, yeah, yeah, and it's our funding model. Um, we'd love to see other areas develop something similar. It might not be the exact model that's needed. I mean, Dublin obviously has probably got the biggest homelessness problem when you look at the stats, but there could be models that could be replicated across the services with the Department of Housing and Department of Health. Um,
Yeah, and I think that's why it's so great that you have it there, and that you're embedding all of the kind of the monitoring and evaluation and the reflection and the pilots into it, and that learning can be shared across the
yeah.
country. I have another question here. So just to remind people that the Q&A box is open. This is from someone called Stephen Donnelly. I'm not sure if it's the previous Minister for Health or it could be Stephen from Mental Health Reform. He said, thanks so much for your presentation, Naomi, and the heartfelt testimony from the service user. I'd like to know how dual diagnosis is acknowledged in treatment, and as the service continues to grow. So two questions again in here. So how dual diagnosis is acknowledged and looked at, and then as the service continues to grow, what would success look like for you in a few years' time, both for people accessing the service and for the wider system?
So, in terms of dual diagnosis, we run a model of parity of esteem. So, physical health and mental health have parity. So, we don't exclude people on the basis of, somebody having a dual diagnosis. Parity of esteem is really, really important. We take people in with mental health issues. We have to work within our scope of practice. We do have mental health nurses, and we purposely have got a skill mix of registered general nurses and mental health nurses for that reason. So there's almost cross-fertilization of understanding. We work really, really closely with the inclusion mental health team. So if people do come in with a dual diagnosis, we work closely with them. We don't exclude people. We don't have people going from pillar to post, which we know happens in services or can happen in services, and then people fall through the cracks and then nobody works with them. We have parity of esteem. So that's the most important thing. In terms of what does success look like, it'd be lovely not to have the service, wouldn't it?
Yeah, there you go.
Ultimately, that's what success would look like. But I think improving our outcomes would be fantastic. We can only do that if we work in collaboration with housing and housing first models and all of that, because like you said, if we don't have the appropriate housing, and it's appropriate housing, there's a combination of short term, sorry, we don't really want many short-term accommodations. We want really, really good long-term accommodation for people with complex health needs or the aging population that we have. We want suitable independent living. We want housing first models. It's not one size fits all. So without that, I think we you know we need to work in tandem with that. So for me, that's what success looks like. Our outcomes increasing,
Yeah,
positive.
and I completely agree. Those of us working particularly in homelessness, is we're trying to do ourselves out of a job. We want to get to a point where everyone has affordable, safe, secure
Yeah.
homes. Just well, I have you for a couple more minutes. So if anyone else is thinking of any questions, but I just wanted to ask you a little bit more about the care navigators. I hadn't heard that before, and you did say that it's something quite new to Ireland. Can you tell us a little bit more about that? Because it sounds like something that we talk about needing, but hadn't put that kind of label on it.
Yeah, so care navigators will work with clients that at the point of entry into our service. So when people come in so we've got two care navigators, one that sits in step up, step down, and one that sits in stabilisation currently. And they will work at the point of entry into the service for people with complex discharge needs. And they will work really, really closely with the client, with the project worker, and with the community supports to reconnect them to the community and to work closely with complex housing needs they might have. So it's a real focused piece of work that they will do. So they'll have a small caseload that they'll work with and support that. They'll also support people to connect with methadone clinics out in the community and any external appointments that people need to go to. So they will do some very practical things with people as well as that legwork
Mm.
from a social perspective.
Yeah, it's a great idea.
Yeah, it's a model that started out in the UK, and you can tailor what the care navigation looks like to this particular service that you're working in.
Mm.
So we've tailored our care navigators specifically to meet an unmet need within our services.
Yeah, it's brilliant. It's great. And the other thing that really jumped out to me was about this excuse me, the step up, step down and the hospital admission prevention. Are you capturing that data, for whenever it'll be, I don't know, another year or so down the line to say these were the numbers of either early discharges or, preventing someone from being admitted to acute hospital?
So we capture the data, but I suppose it's really difficult if you get somebody before they go into hospital, it's really difficult to say whether they would go into hospital or not.
Yeah,
It's really
fair.
hard data to capture, and in terms of people being discharged from hospital and early discharges, we do have that data. What we don't have actually, and we need to work harder at this, and hopefully this will be part of the HSE review because the HSE will be reviewing our services, which is great over this year. Hopefully, we'll be able to firm up a bit of a stronger link between the follow-up. So, you know, did people, is there a revolving door of people going in and out of hospital, or have we had some impact around there? So that's a bit of a collaboration between us and the HSE and working that through. But I'd like to see
Yeah.
that as part of the review. If anybody from the HSE is on here, I'd love to see that piece of collaboration.
Excellent, excellent. And the other thing I want to give you a chance, the National Drug Strategy public consultation is open at the moment. I was going through it yesterday, and there's obviously all the different pillars and things like that. But something that I was obviously highlighting was the need for, the housing supports. But if there was one thing that you thought this would be a really, really important, because I'm sure there's people online listening in who'll be doing their own submissions to the drug strategy or their organizations. Is there one thing that you're like, this would be this would be something really, really key to include in the next national drug strategy?
I know probably people that from Dublin Simon will look at me and roll their eyes, but women, if we want to make an impact on generational trauma and we want to make an impact on ending homelessness, if we don't focus on women who are the main caregivers, rightly or wrongly, they are, then we are not impacting where we need to, and women aren't accessing our services in the way they should, and we need to be creative and we need to think really, really carefully about how we engage women in our services. That's the biggest impact I think we can make generationally.
Yeah, no, and I thought that as well when you said about the pre and postpartum, the beds and that intergenerational piece. You're so right, and we see it across um, different areas as well around kind of gender equality and stuff of, the support given to women will make a huge difference for the generations coming down the line.
Yeah.
Um, thank you so, so much. We'll wrap. We're 2 minutes early. I'll give you back 2 minutes of your morning.
Thank you.
Um, really, honestly, appreciate it so much, Naomi. It was really, really fascinating, and I think for me, the part that you can just really, really tell how much you care about people in the services and accessing the services and your teams. So thank you so much for everything that you're doing. Keep up the amazing work, and yeah, we'll be watching and looking to hear, all of the stories and things that are coming out. So thank you honestly for your time. I know you're very, very busy. Really appreciate it, and we'll talk to you soon.
Thanks ever so much, and thank you to the team that I work with. If anybody's on the call, you're massively appreciated.
Thanks so much, everyone. I'm going to end it off there now. So we'll see you
Thank
all
you.
soon. Thanks.
Bye. Bye.